All right. Hello, everybody. Welcome to today's monthly webinar. My name is Dan Dimitri. I am the CEO of PharmaForce, but more importantly for today, I am the moderator of the webinar as the great Anthony Velasquez, my partner in crime here, is going to do the presentation. Our format is this. We present for 30 minutes, and at the end of 30 minutes, or anytime during the presentation, go ahead at the bottom of your screen. There's a QA button. You can write any question you want. Maybe we answer it during the presentation, or maybe we just wait till after the 30 minutes. At the end of the 30 minutes, we open it up. We start answering the questions. We even unmute you if you would like to ask a question live. And sometimes there's a lot of dialogue and we go well over an extra hour. And sometimes there's no questions at all. Who knows what's going to come out of this, but the key is we're doing these webinars because we learned a lot of things, both working and managing 340B programs for covered entities and now being on the TPA side, a lot of tips and tricks, things that we wish we would have known back when we were in your shoes. So hopefully you find today's session valuable too. So with that said, I will pass the ball over to the magnificent, the great, the amazing Anthony Velasquez.
Thank you, Dan. Thank you for those words. All right, so let's get started. Thank you for joining. As I always like to start with a small anecdote or story. But do you remember when you first went to college, right? Those of you, I'm sure we have a lot of pharmacists joining, but you start your program, you start learning all of these things. You start taking new classes every semester, and you're learning something new, and you're learning new complex things and different theories and different classes. You're excited about everything you're learning, but then you realize how much you don't know, right? And I like to compare 340B to that because 340B is such a large program, and there's so many things that even someone that has been in a program for over a decade, you're still learning, and every day you're learning. There were things that I learned the last webinar from some of you in that you share. So as we expand this session of optimizing your 340B program and cutting costs, I'm going to share some new topics and new ways that you can cut costs that hopefully you haven't heard before. Hopefully these are things that are new that you can implement in your program today. So as Dan shared, my name is Anthony Velasquez. I've been in the 340B space for over a decade, working for different entity types from health centers to hospitals to large IDNs. Now I have the pleasure of serving as the Chief Product Officer at PharmaForce, where I focus on technology and all our product offerings as it relates to our contract pharmacy application. So let's go ahead and get started. And again, hopefully you learned something new today, something you had not heard before. So the agenda for today is going to focus on 5 different things related to ways you can optimize your program. Hopefully you'll catch things and that you can go back and implement today or look into in your 340B program. We're going to start by talking about 340B account setups, making sure, especially those of you that have really large health systems. I remember once managing a health system that has 65 plus purchasing accounts, right? So that's a lot to keep a track of. So we want to talk a little bit about what's the best practice for setting up those 340B accounts. We want to talk about infusion centers too. This may not apply to those of you that are grantees, but those of you that are hospitals and managing infusion centers, I want to talk a little bit about what are some of the ways that you can optimize your infusion centers the best. So I want to share that. We want to talk about orphan drugs. So those of you that are subject to the orphan drug exclusion, again, this is not going to be every single covered entity, but those of you that are subject to the orphan drug exclusion, I want to share some tips on how you can optimize that process. We want to talk about WAC-Impact. Those of you that are hospitals that are utilizing a WAC account because of a 3-way split in your mixed use setting, we want to talk about ways that you can monitor that to make sure that that's not costing you a lot more money than it should. And then I want to talk about non-cover drugs blocking and management. So some of these things are going to be specific to all entity types. Some of these things are going to be specific to more of the hospital world, but hang with me. I think there's going to be some good information here for everyone joining this call. All right, so let's talk about 340B account setup. As you all know, you are going to, whether if it's a contract pharmacy or if it's a mixed-use setup, right? You're going to have your ship to bill to set up in the OPA database. If it's a contract pharmacy, you're going to have it registered as a contract pharmacy, and that would allow you to go and register or request a 340B account, right, for your contract pharmacy or for your mixed-use setup. And here's some of the things that you want to consider. Number one, you want to consider whether you have multiple areas of purchasing. For example, so if you have a hospital and you have multiple inpatient pharmacies, maybe you want to consider a structure where you set up your account so that you are accumulating in one accumulator. Your parent and your child hospitals are accumulating there, but then you're setting up accounts at all your separate inpatient facilities to pull from that same accumulator. Or maybe you want to set up something like a central replenishment model as well that might benefit your facility. So you want to consider, your setup, your structure, your pharmacy structure to make sure that you're setting up the 340B accounts, that is your 340B, your GPO, your WAC, in a way that best meets the needs of your facility, especially from a mixed-use perspective. The contract pharmacies are pretty straightforward. You're going to request one 340B account. There are going to be instances, and this is one that I've mentioned in the past in other webinars, there are instances where you may have a contract pharmacy relationship where you are going to need to set up multiple 340B accounts. So you may have a primary 340B account. You may have to set up a secondary 340B account for certain types of drugs that you can only buy through a certain distributor, certain drugs that you can only buy from a certain wholesaler or directly from a manufacturer. So you want to keep account, especially in the specialty world. You want to make sure that you are maximizing all of the NDCs you can purchase by ensuring that you have all of the proper accounts set up. This is something that happens very frequently, for example, in an Accredo situation, where if you have an Accredo specialty pharmacy, you might have your AmerisourceBergen account as your primary, but you can set up a secondary account to buy some other products that they obtain through a specific distributor. So you want to be aware, you want to ask about that. If you have an Accredo specialty pharmacy or other specialty pharmacy, an Optum specialty or something along those lines, you want to make sure that those secondary accounts are properly set up, open, and configure with your TPA to make sure that you're maximizing every single NDC that you can purchase. Another thing that's really important to note, especially for those of you that have clinics, is how are you purchasing for your clinics? Maybe you have a process in place where the clinic is requesting product from the inpatient pharmacy, right? And you have to keep a log or keep a track of that. Or maybe it's an instance where you might benefit from setting up a specific 340B account for that clinic specifically, that might be buying some asthma products, or might be buying some catalogs and some other products. If you allow, some of the examples that I've seen is where a hospital will allow the clinic to purchase via their mixed use purchasing, but those charges are not feeding the accumulator. So you want to be careful that if you have clinics that most cases are on different EMRs, that the charges are either feeding the main accumulator appropriately and correctly, or that maybe it's in your best interest to have a separate account for that specific clinic. And then the third area, and this is a big one, and I can tell you from experience, I found working at a facility one time back, I want to say 7-8 years ago, a situation where I was managing a 340B program. One of the child hospitals was buying this very rare drug from one distributor. It can only be purchased from this distributor. You had to submit very specific patient information to buy this drug. During the compliance review, we found that account was only set up as a WAC account, and there was no 340B account open. And the price difference between each purchase was about $8,900 for each package. So if you are a hospital facility that has a lot of child sites, and you have to buy from different direct vendor purchases, you're not buying everything from your primary wholesaler, you want to make sure that all of those direct vendor accounts, especially in the mixed use setting, have a 340B GPO and WAC, especially if they're doing an EDI interface. If they're not doing an EDI interface, there's other ways that you can do it to maintain compliance, but you want to make sure that you have all of the proper accounts open and not just a certain accounts. I've even encountered situations where reps will come into some of the clinics and will help set up accounts with the clinic directly under the hospital and start purchasing at 340B or a different type of pricing. So if you're running a hospital, maybe you're new to a 340B program like I was, where I came into a hospital that had 100 million plus worth of purchases, and then you have to figure out everything that is being purchased. Focus on direct vendor accounts. That's one major area where you could find opportunities to optimize your program and even opportunities to make compliance better. The second part that I want to mention, this is one that I see very often, and it's around infusion center setups. Most of the time, at least some of the hospitals that I see frequently, and this is things that I've seen when I worked on the 340B program management side, setups that I've seen working on the TPA side, where an infusion center that is a 340B island, every single administration that is done in that infusion center is 340B eligible. That infusion center is going through the mixed use accumulator of the hospital with the hospital's chosen or selected TPA. And there's pros and cons to that. However, the main thing that I want to highlight is that it might be worth looking into setting up a separate inventory for your infusion center. So split ordering versus direct purchasing on your infusion center administrations might not be the best idea to split order in that area. Number one, there is always in some TPA type of forced sort of initial purchase has to be at WAC. So most hospitals that are going live and you have an infusion center, maybe you're going live to 340B or for the first time, or you're switching TPAs, or one of those scenarios, that initial WAC purchasing on high dollar infusions can be very, very high, where that's not necessarily the case if you have a dedicated 340B account for your infusion center with a dedicated and separate inventory for your infusion center to serve only those patients that are treated in that infusion area that is 340B eligible. There's other policies and other procedures that have to be in place to ensure that there's no diversion outside of that area, but it's very important that you set up your infusion center structure in a way that can optimize your purchasing and not lead to an increased amount of WAC spending. One of the other scenarios that I've seen is crosswalk challenges. Depending on your TPA, and mostly it's not even TPA related, but processes for administrations or infusions in an infusion center sometimes very often lead to utilizing two different vial sizes to make a dose. So you might have a 500 milligram vial and a 250 milligram vial, and combining that to make 750 milligrams, and that is the dose that's administered to that patient. However, that can be a challenge to accumulate with certain TPAs if there is a single charge code for that administration. So you want to make sure that you look into how your infusion center. I will look at your infusion charges and purchasing separately because it's such a high amount of purchasing compared to the rest of your mixed use program. Again, if you're a grantee, this may not apply to you per se. This is more on the hospital side for hospitals that have infusion centers. But the point here is you can reduce your spend significantly. And there's challenges like, having the space for a separate inventory and things like that. But this can be a very big way to optimize your purchasing, reduce your spending immediately by carving this area out of your mixed use purchasing. Going on to the next one, and this is about an orphan drug list. Again, this is subject to hospitals, critical access hospitals, sole community hospitals, other hospitals that are subject to the orphan drug list. So this does not apply to everyone, does not apply to grantees, does not apply to dishes or other larger hospital types. So the point here is you want to have a process in place for managing your orphan drugs. You want to know whether is your TPA doing this on your behalf? Is your TPA blocking orphan drugs on your behalf? Or do you have to do that yourself? Do you have to ensure that certain NDCs are not being purchased on a 340B account because they are an orphan drug? One of the things that we provide at PharmaForce, just because we want to help the community, we know how difficult this is to track. We provide a free orphan drug list on our website where you can go every quarter. We update it based on HRSA updates. We look at the OPAID, the OPAIS website, and labeler code changes there. And we provide a list of the NDC level for free on our website. We have other 340B program managers in the 340B community that share updates with us, like, hey, I was able to buy this drug at a voluntary pricing, or I was able to get approval to buy this drug at a 340B like pricing. So you want to utilize resources like our website. Some of the wholesalers have really good resources on orphan drug lists. Ultimately, you want to find opportunities where you can buy at a 340B like pricing, where the manufacturer will offer a voluntary pricing that sometimes is the ceiling price. Sometimes it's a little bit more, but it's a lot more discounted than it would be regular by buying a regular pricing. And there's opportunities for savings here. There was a drug, and actually it was an asthma drug that had been listed on HRSA's orphan drug list, and the manufacturer came out and said, we do not consider that an orphan drug, and we provide that at a 340B like pricing for any covered entity, right? And that was something that our customers did not know. We were able to find that out and share that with them when we were able to include that drug and buy that drug at 340B pricing, and our customers were able to access that product. So orphan drugs are another way, another process. This is like, I was sharing the examples of, being in college and finding, taking this new class that you didn't know before. This one was actually newer to me because I had not come from a hospital, background that dealt with orphan drugs, but I've certainly learned a lot in the last few years helping some of our critical access hospitals with orphan drug list management. All right. The next one, another one, especially for hospitals on the line. This one is really, really important. If you are utilizing, it doesn't matter what TPA you're working with, but if you're utilizing a replenishment model and you have a 340B GPO and WAC account for replenishing your mixed use inventory, you want to listen to this. This is one of those areas that I think is heavily neglected. I sometimes, work with hospitals that are going live. We have a special report that talks about WAC-Impact. Essentially what this is, instances where buying the drug at the WAC price was higher than what you would have paid at GPO. So you're buying drugs at WAC naturally because of your cycle of accumulations and purchasing. Those are going to a WAC account, but it is more costly on that WAC account than it is at GPO, right? So basically you have the WAC account because you're in the 340B program. If you don't have the 340B program, there's no need for the WAC account where you're paying wholesale acquisition costs. And some of the reasons for the WAC, the high WAC impact can be related to things like Maybe you're buying a brand new drug. There was a new drug that was added to the formulary. You're buying that for the first time. You've never administered that drug, so you don't have accumulations. And I think in those cases, that's okay. That's an acceptable reason for a WAC purchasing. But there's other situations where maybe you're under accumulating significantly on a product. Maybe your billing unit per package or your multiplier in your crosswalk is causing you to accumulate at a tenth of the level of the drug, where you should be every administration should accumulate a full package, and you're accumulating a tenth of that. So there can be situations where it's simple as fixing your crosswalk. I've seen situations where the charge is coming over incorrectly, or the charge is not coming over at all from the electronic medical record. Situations where the pharmacy is filling up emergency carts, right? This is something that happens often, where the pharmacy has emergency carts throughout the hospital. Those are being filled, those drugs are being purchased through the mixed use accounts, and hence those drugs end up, whether they get expired or it's a new emergency card, something like that, but they end up leading to increase in WAC purchasing. Like I said, one of the ones that I've seen too is just most frequently it's crosswalk related. I think that's probably safe to say that's the number one reason in many instances for additional WAC purchasing. I know previously in 340B, WAC percentage was something that was tracked a lot. It was something that the industry was tracking very closely, and you want to be about a 10% WAC and or under 10%, et cetera. I don't know that that's really the case now. I think the right metric to track as it relates to WAC is the overall WAC impact, right? There's instances where you're buying a drug at WAC and it might be cheaper than it would have been at GPO because it might have a sub WAC pricing. So you want to track the impact. You want to track that number is within a reasonable range, and that varies, right? If you're a very large health system IDN and your WAC impact is $5,000 a month, $10,000 a month, that might be okay. That might just be the nature of managing a 340B program and you're a large IDN. If you're a really small dish facility and you have a $25,000 WAC impact, that might show signs of something a little bit more concerning, and that there needs to be a monthly monitoring. So you want to look at monitoring things like your expire meds, your separate inventory. You want to look at possibly accumulating waste. Maybe you have an opportunity to accumulate waste on insulins, where you're opening an insulin vial. That vial is only good for 25, 27 days, I believe. And once you're not able to use all those units, you have to waste that and you have to throw it away, right? There's cases where you can add in your policies and procedures an insulin waste policy, where you're going to add that insulin waste to your GPO bucket, right? So that's something that you want to look into and consult with your 340B steering committee about a possibility to add that to your 340B program process to ensure that you don't have unnecessary WAC purchasing on your insulin products, which can be very expensive in terms of difference between 340B and GPO or WAC pricing. All right, another one that is a big one, and it's your non-cover drugs, especially if you are a mixed-use facility and you have supplies, you have contrast agents, you have large fluids, you have, in some cases, even anesthesia gases, and you have these types of drugs. Some of them are just they're non-participating, right? You want to have a process in place for blocking these drugs, right? The moment that you see that an NDC was purchased on a WAC account, again, this kind of ties a little bit to the previous point, but one of the ways that you can do is maybe on a weekly basis or even a daily basis, monitor the top 5 to 10 things that went to your WAC account and see what opportunity is there to reduce that unnecessary spend. Maybe it is that, hey, it was a supply, right? And you paid $25 for that drug on the WAC account, but you would have paid 10 on the GPO. So you just have to go into your TPA and make sure you block that. Or notify that as being a GPO only purchase, right, as per your policies and procedures. So you want to have a way that you are tracking these. Again, this is low hanging fruit. This is something that you can do easily to identify. Be careful when you're changing new TPAs, right? If you did a lot of work for years in managing your non-cover drugs, you change a TPA, and that those NDCs are not transferred during the implementation process, you might go back to square one, and then you have to rework that non-covered drug list and block, from the beginning, where you might have put in a ton of work on doing this. And then you also want to see, like, are there drugs that you went to your WAC account because there's no 340B pricing? Maybe it's a non-participating manufacturer. Maybe it's a instance where something's not loaded correctly to your catalog. So that's another area where you want to look at, is there an opportunity to block this drug? Is there an opportunity to send this drug to the GPO account and hence take advantage of a reduced pricing versus, the NDC going to WAC by default? Some of these, I want to highlight a point. Not every covered entity blocks large fluids. I know there's some covered entities have tried to accumulate on anesthesia gas, and there might be ways to do it. It's very complex and very difficult. There might be ways to do it, and I'm sure someone has figured it out. But in general, the knowledge has been that some of those things get blocked to GPO because they're very difficult to track and accumulate on, etc., and are hence added to your policies and procedures to do that. All right, so those are the topics that I want to share today. And I know that time went really, really fast, but I hope that you guys found some useful information in that. I do want to announce the next webinar will be September the 22nd at 11:30, same time. Again, 30 minutes. We really try to be mindful of everyone's time and give you a ton of value in a short period of time and not keep you for an hour and a half. But for 30 minutes, we are going to discuss how to optimize your program by improving your data interfaces. So those of you that have 340B programs, you might think my interface is perfect, I have no problems with it. You might want to come and attend this webinar because I want to share some things that we've learned from taking thousands of pharmacies and CEs live, working on the TPA side, and also some things that I've learned working on the hospital side. So I hope that you sign up for that. You're going to see that email coming out for that. I will share too one last thing. The webinar is recorded. We will be sharing this and sending out an email when the recording is ready. You can go to our website, thepharmaforce.com, and download the webinar if you want to share it, rewatch it. And again, thank you for joining. I look forward to answering your questions.
All right, so for this stage of the meeting, I am going to stop the recording. So no one's going to get recorded if they ask a question.